XYZ, XYZ, XYZ.
And welcome to XYZ. And today we'll start by discussing seizures and epilepsy, which is one of my favorite topics. So in terms of objectives, we'll be talking about the definitions, the causes of seizures, pathophysiology, different types of seizures, the complications, bit of history taking, and investigations, and basic life support. So we start with definitions. Key definitions that are important in the understanding of seizures and epilepsy as a topic, and we start by defining the word seizure. So a seizure is a neurological event, meaning it's just one, in which there is sudden and abnormal massive release of impulses in the brain in an uncontrolled manner. And these manifestations of this uncontrolled release of electrical impulses manifest differently, and that depends on the part of the brain and the extent of the brain that is affected. So manifestations could be different. You could have motor manifestations, you could have sensory manifestations, you could have autonomic manifestations, you could have psychiatric manifestations, and all this just dependent on the part of the brain that's affected. For example, if it was the visual cortex affected, it will be manifesting as a visual manifestation of a seizure. If it's the motor cortex that is affected, it will be a motor manifestation of a seizure. And yes, that's important to understand. And so we move on to the next definition, which is a fit or a convulsion. A fit or a convulsion is not the exact same as a seizure, because a fit or a convulsion is just a motor manifestation of a seizure in which there is this absolute increase in motor activity and jerking movement, which tends to occur in tonic-clonic seizures. Good. Now we define epilepsy. Epilepsy again is slightly different in terms of epilepsy being a chronic neurological disorder that is characterized by recurrent and provoked seizures that are separated by a time lapse of at least 24 hours. So number one, it's a chronic condition and it's characterized by recurrent and unprovoked seizures. Recurrent meaning it's more than one seizure for it to be considered epilepsy. Unprovoked meaning there tends to be no identifiable organic cause for the seizures. And again, not every seizure is epilepsy, and so whenever you have recurrent unprovoked seizures that you can't seem to identify any organic cause, that's epilepsy. Status epilepticus is a seizure that lasts more than 5 minutes, or having more than one seizure within a 5-minute period without returning to baseline or returning to normal conscious levels. This is a medical emergency and needs to be addressed as fast as possible. You can imagine this, what kind of crisis this is, because it's a seizure that is not stopping, just keeps going on, and it will ultimately even prove fatal. And an epilepsy syndrome refers to composite signs and symptoms that follow a well-defined and characteristic pattern. So particular demographics, so particular individuals who have particular symptoms of which seizures are part of them, and all that put together becomes a syndrome. They call it an epilepsy syndrome, and there are various types of epilepsy syndromes. So we talk about the causes of seizures, and for causes of seizures we use the mnemonic vitamin D. You go out, get some sunshine, you get some vitamin D. The V stands for vascular, and this could refer to strokes or to high blood pressure. Strokes could be acute or chronic strokes. High blood pressure in conditions like eclampsia, renal failure, etc. I for inflammatory or infectious, so it could be meningoencephalitis, it could be granulomatous meningoencephalitis or meningoencephalitis of unknown origin, could all lead to seizures. And traumatic, so someone could fall, hit their head, be hit on the head, and you have traumatic brain injury, which could lead to seizures. And toxic, such as some drugs or some toxins, drugs like ivermectin, warfarin, ethylene glycol, could also cause seizures. and anomalies, congenital anomalies such as hydrocephalus and cortical dysplasia will also cause seizures, and metabolic causes as well, such as hypoglycemia, low blood glucose, and accumulation of toxins due to either renal or hepatic failure. So you have uremic and hepatic encephalopathy, which may also cause seizures, and then idiopathic seizures, in which case we said, no identifiable organic cause, epilepsy. Nice. And then brain tumors will also cause seizures, neoplasia, different types depending on where that tumor is located. And then finally the D is for degenerative. So the brain wears out, the neurons don't work the same way, the physiology and the chemistry in the brain is altered, and ultimately you have seizures manifesting, particularly in Alzheimer's disease. Nice. So just to emphasize, as you've seen, there are various etiologies for seizures. So seizure is just a symptom like any other. It will be it's a symptom just like pain, just like a cough, and it ought to be investigated for the underlying cause. Nice. So we look at the causes of seizures by age. So there are various differentials to consider depending on the age of the patient, and in neonates and infants, CNS infections and developmental disorders and perinatal things tend to be more common. Perinatal infections, perinatal trauma, perinatal hypoxia, perinatal drug withdrawal, drugs that the mother was taking, metabolic disturbances would also be a cause. And then in older infants, febrile seizures, CNS infections, developmental disorders, genetic disorders, trauma, because they start to play a bit. Children below 10 tend to play a bit, and they may fall and they may hit their heads, drugs as well, etc. And then in adolescents, traumatic brain injury, because this is the age where adolescents like fighting, playing dangerous games, may hit their head somewhere and may end up with seizures. Again, infections, genetic disorders, and illicit drug use would also be considered as differentials. And then in adults, alcohol withdrawal, delirium tremens, manifestation is seizures. So drug abuse is a suspect in adults having seizures, particularly the new onset. And then traumatic brain injury could be another cause from accidents or from whatever cause. And then brain tumors, illicit drug use, metabolic disorders, infections, all those in adults. And then in older adults, particularly those aged more than 60 years, traumatic brain injury will be there. But then now you also have cerebrovascular disease becoming more prevalent. Neurodegenerative conditions like Alzheimer's become more prevalent. Brain tumors as well, abscences, and metabolic disorders all begin to feature more strongly in these age groups. Nice. So we look at the pathophysiology of seizures. So what actually happens? So we look at the various etiologies for seizures, and the vitamin D mnemonic, and you can imagine, so they're different because some will be more focal, localized to particular areas, and others will be more general, particularly those that are in blood. Those are the systemic causes of these seizures, and so those etiologies may cause different manifestations. And what they all do in one way or another, they'll alter the neuronal membrane, or they may alter the neurotransmitter balance within the brain, and you end up with an excess of glutaminergic activity, which is excitatory activity, and or a decrease in GABA activity, or both. You could have both happening, and that leads to increasing firing frequency and amplitude of the neurons in the brain, and this spreads to adjacent neurons, and this uncontrolled firing of neurons manifests as a seizure. It could be motor, sensory, autonomic, or psychic manifestations. Nice. So what are the different types of seizures? You have focal, partial seizures, generalized seizures, and unclassified categories. So for focal or partial seizures, you have simple partial seizures, complex partial seizures, and partial seizures that are secondarily generalized. And simple partial seizures are just the seizures which tend to be just a small part of the brain which is affected. So it's a smaller part of the brain that's affected. So even in terms of the manifestations, it's just probably going to be just depending on the part. So it's just going to be either just purely motor manifestation or sensory manifestations or autonomic or psychic. And because it's just a small part of the brain is affected, consciousness is generally not altered. But then for complex partial seizures, a relatively larger part of the brain is affected, and you may have more than one manifestation. So you may have combinations, you may have both motor and sensory manifestations, both autonomic and psychiatric, whatever permutation of the manifestation may take place. And consciousness may be altered in complex. Consciousness altered in complex partial seizures. And then you have these seizure types called partial seizures that begin at one place, and then so the partial seizures that are secondarily generalized, they begin at one spot and then they spread. So they spread and eventually they may spread to the entire brain, and so you end up with a generalized seizure. And so for generalized seizure, there's larger parts of the brain, both hemispheres being affected, and generally the consciousness may be affected depending on the extent, and so larger parts of the brain are affected in this case. So examples: tonic-clonic seizures, which are formerly known as grand mal, then absence seizures, formerly known as petit mal, tonic seizures, atonic seizures, myoclonic seizures. We'll look at these ones in the next slide very briefly. And then unclassified, you have neonatal seizures and infantile spasms. Good. So we talk about tonic-clonic seizures. So we're looking at the different types of generalized seizures. So tonic-clonic seizures, so one of the most widely known, and it has two phases, a tonic and a clonic phase, and we'll look at that. So it usually has, in terms of its occurrence, it has three stages. There is the initial stage, is known as the pre-ictal, also known as the aura stage, also known as the prodrome, and then you have the ictal stage, and then you have the post-ictal phase. So the pre-ictal phase is basically the warning sign, or when the alarm bells start to ring, the warning bells, that there is something that is abnormal. There is abnormal electrical activity that is beginning to take place in the brain, and so this may manifest as hallucinations, as dizziness, abnormal smells, just anxiety, numbness in some parts, and it's a warning sign. And generally, even for people who usually have these seizures, they become aware that there is something that's about to happen, and they're about to have seizures. And this is a pre-ictal, or the aura phase. Doesn't always happen, and because it's the beginning, it's actually part of the seizure. It's just the beginning of the altered electrical activity in the brain. It's also part of the seizure in essence. So you have the next phase, which is the ictal phase. For tonic-clonic seizures, there's tonic phase and then there's clonic phase. Tonic phase is a phase of stiffness, where the body is stiff, muscles are stiff, and this is followed by a clonic phase, where you have relaxation, and then you have alternation between these two phases, and that leads to jerking movements, because contraction, relaxation, so it leads to this convulsive movements. And the tonic phase, which is this stiffness phase, is characterized by a loud cry known as the epileptic cry, due to the contraction of thoracic muscles, so the louder cry, and then back that's arched, stiff body, may have incontinence in this phase or in the post-ictal phase. And then you may also have frothing of saliva, biting of the tongue, blinking of the eyes, among other movements that will be taking place. And then finally you have the post-ictal phase, which is the phase that comes after everything. So this is after the seizure. This is a phase of tiredness. Unconscious, the person may still be unconscious, and they're just exhausted. Their sphincters may let loose, so they may pee and poop themselves. They may swell their pants, and they may end up have very weak limbs. It depends. Not all people get back to consciousness at the same time, so it varies between individuals how fast they get to consciousness, and it depends. Some may also have severe cardiorespiratory effects. Nice. So now we talk about a tonic seizure. Tonic seizure is just characterized by the phase of stiffness. So it's just the tonic phase alone. So just the stiffness features, back act, these flexed upper limbs, stiff body, loud cry, all that stuff, just the tonic phase. So it's just a seizure characterized by this increased tone. And then you also have a seizure type known as a tonic seizure. The prefix A implies lack of tonic tone. So it's loss of muscle tone. So what happens is that, for example, a patient will be walking, and then all of a sudden there's sudden loss of muscle tone and control of muscles, and the person will fall head first because they can't control themselves. So they'll have what are known as drop attacks. So they'll report repeated episodes of falling, just like unexplained. They just keep falling for reasons that they can't explain, and they'll probably injure themselves a lot due to this drop attacks. So that's a tonic seizures. And then now we look at myoclonic seizures, which is another type of generalized seizure. It's characterized by non-rhythmic jerks resulting from involuntary muscle twitching. So you can see this EMG over here showing this electromyography, that is showing non-rhythmic jerks or spikes that don't follow the normal rhythm, which is characterized by involuntary muscle twitching, and it normally targets the upper limbs, the upper extremities, and it may be perceived as electric shocks. So these people may feel like they are being shocked. So probably someone will be carrying something, be carrying a plate, or in the morning they're brushing their teeth and they're holding their toothbrush, and then suddenly they feel this sense of shock, bzz, and then they'll drop whatever they are carrying, whether it's a plate or whether it's a toothbrush or whatever, and that's how it tends to manifest, and most commonly occurs in the morning, and it's triggered by stress or sleep deprivation. And then different types of epilepsy syndromes may cause myoclonic seizures, such as juvenile myoclonic epilepsy, Lennox-Gastaut, Rett syndrome, progressive myoclonic epilepsy, Dravet syndrome, maybe among others, not exhaustive. Yeah? And then absence seizures, as the name implies, it's a state of absence. So what occurs in absence seizures is that it's a generalized non-motor seizure. It's a non-motor seizure, still generalized, but its manifestations are non-motor, and it manifests with loss of consciousness without a change in muscle tone. And what happens is that person will just start staring blankly. And they may have rolling of the eyes upwards, fluttering of the eyelids, and then they cease whatever they were doing. So for example, if they were focused in class reading, or maybe they were paying attention to class, so it tends to occur in children, that's why I'm using class as an example, and they were paying attention to the teacher, and then all of a sudden they're in this trance that they're not even snapping out of, so they're just staring, and they're not responding. There's no response. You try to snap them out of that trance, they don't respond, and this may be misdiagnosed as ADHD, because ADHD also tends to have those kind of trance states. But the difference is that for absence seizures, where these children are in this state of this staring, vacant stares, they don't respond. But for ADHD, you can snap them out to be like, hey, and they'll respond. But then for absence seizures, they won't. So that's what absence seizure is also formerly known as petite mal seizure. It's a non-motor seizure, but no change in tone, but it's all about which part of the brain that is involved. Good. And then in terms of complications, so what could go wrong with what we've discussed so far in terms of the seizures? So many things could go wrong, and these are the complications of seizures, and it will be divided into acute and chronic. So irreversible brain damage could occur due to hypothermia, cardiorespiratory deficits, excitatory toxicity, and all this could lead to necrosis of the brain tissue known as cortical laminar necrosis. And then you could also have post-ictal lactic acidosis. So you have accumulation of lactic acid due to excessive muscle activity, and so you have accumulation of lactic acid, and that could lead to metabolic acidosis. And then physical trauma, due to, it could be self-inflicted, such as tongue biting, or it could be due to falls, So you end up with joint dislocation, head injuries and all. And then polytrauma, so imagine from accidents. So person driving, and then they have a seizure, and then get a very serious accident. Person is swimming, then they have a seizure, a very serious accident, so they'll drown. And so all these will be complications of seizures. And then seizures epilepticus, which is this prolonged seizure going on for long, which is life-threatening and a medical emergency. Chronic complications include psychiatric manifestations, because in seizures the chemistry of the brain tends to be altered. So we may have conditions such as anxiety, depression, cognitive impairment, psychosis, and psychosocial disturbances taking place due to seizures, because the chemistry of the brain is altered. And then sleep disturbances and insomnia occur, as well as bone disease, particularly due to the drugs, that anti-epileptic drugs, which cause osteoporosis and osteomalacia. And then finally, SUDEP, which is sudden unexpected death in epilepsy, is another topic on its own, but it occurs, and it tends to occur during the seizure or immediately after, and it will be due to different reasons. Will be cardiorespiratory failure and among others, and tends to occur in young people, and you just have the seizure and then they never wake up again. So we talk about epilepsy syndromes. There are different, some that occur in childhood, others that occur in adulthood. Examples of the ones that occur in childhood: juvenile myoclonic epilepsy, Lennox-Gastaut, West syndrome, Landau-Kleffner, Dravet, etc. And then in adults, you have mesial temporal lobe epilepsy, frontal lobe epilepsy, and catamenial epilepsy, which is this epilepsy that tends to occur during periods. Good. And then, so we look at history taking. So as we've emphasized, seizure is just a symptom that ought to be investigated further for the underlying cause. So you need to have an idea of the date and age at first seizure, whether the person had a presence, an aura during the seizure, ictal manifestations, so what happened. And most of the time this will be given by another party, so an observer. So it will be maybe a collaborative history for the person who observed this person as they were having their seizure, because the person having the seizure is usually unconscious. And then post-ictal manifestations, so what happened after the seizure. Did they pee themselves? Did they have all that stuff that we mentioned prior? And then diurnal variations, does it occur during the day or at night? And then triggering factors, try and find, is it stress, is it lack of sleep, is it particular drugs, is it any trauma, is it anything that you can identify that may be a trigger for these seizures. And then the frequency and related admissions, to have an idea of how severe of a case you're dealing with. And then maximum seizure free period, so how long the person has gone without having seizures. And then the seizure types, from what we've discussed, the features of specific seizure types, and then those features may help you identify the specific type of seizure a particular patient is having, as well as knowing injuries and complications related to the seizures and addressing them adequately. And then drug history, both for anti-epileptic drugs as well as other drugs that may cause seizures or may interfere with the activity of the anti-epileptic drugs. Good. And then family history, to know if there is any genetic history, any family history, because you may have genetic causes of seizures. And then after taking that history, you also want to do a physical exam, looking for scars, injuries anywhere, any bite marks or any tongue biting and anything that will imply falls or any injury due to seizures. And then from there you want to do investigations. Top of the list, EEG, electroencephalogram, and then you also want to do imaging, MRI, or CT, as well as lab investigations to look for the various etiologies that we mentioned before. And then finally we'll talk about, just briefly, about basic life support. So this is what to do when someone is having a seizure, how to help them out. This is a graphic from the Epilepsy Foundation. So you want to stay with the person, take care of them until they are awake and alert, and keep them safe. Put away move any objects that may harm them, that may hit them or injure them as they're having convulsions. Turn them to their side, and ensure their airway is clear. Ensure they don't choke on their secretions, and ensure they don't have anything, any gum that they were chewing in their mouth to avoid choking. And if the seizure lasts more than 5 minutes, or the person is pregnant or seriously injured, and if it's just any case based on your judgment where you feel needs urgent medical attention, you need to call 911 or emergency medical services. And they don't restrain, don't put any objects in their mouth to prevent them from biting their tongue. Don't do that. But then if you have some rescue medicines that you can have been given by healthcare professionals, you should give them to try and stop the seizure, particularly in Seizures Epilepticus. So that's it. Thank you very much. I hope you liked this session and you learned something. Follow, like, and subscribe to this channel. Thank you very much.
XYZ.